The following podcast is part of a certified educational activity titled Unlocking the Benefits of Synergy Between Therapeutic Advances and Holistic Care in Gastric GEJ Cancers. Current evidence, practical guidance, and point-of-care tools for implementing a multidisciplinary approach to modern patient care. Access the entire activity and complete the post-test at peerview.com/BBD860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Manish Shah from Weill Cornell Medicine in New York. I'd like to welcome you to this educational program titled Unlocking the Benefits of Synergy Between Therapeutic Advances and Holistic Care in Gastric and GE Junction Cancers. I'm here with two of my colleagues, Dr. Brandon Swed, he's a hematology oncology fellow with us, and Hilary Hayesen, who is a nurse practitioner in our group. Thank you both for joining us on this important education series.
Thanks for having me.
Glad to be here.
We hope this program will provide you practical guidance on implementing a multidisciplinary approach to gastric cancer management. I will be presenting on standards of care for gastric cancer with a focus on metastatic setting. We will also talk about how we think about sequencing treatments through the first 3 lines of therapy. Dr. Swed and I will then discuss several cases in the locally advanced setting and the metastatic setting. In addition, Hilary will provide us with insights and perspectives on patient care management. Additionally, we'll talk about a look to the future and new treatments on the horizon. But now, let's begin with the current therapeutic strategies in advanced gastric cancer and what it has meant for our patients. Gastric cancer is the second leading cause of cancer death worldwide. There's a wide geographical variation. 50% of new cancers occur in developing countries. In the United States, just over 27,000 patients will be newly diagnosed and responsible for 11,000 deaths annually. Unfortunately, this disease has a poor prognosis. Median overall survival for most patients is less than a year. We've learned a lot about gastric cancer and the molecular features of the disease and have begun to identify important subtypes. The Cancer and Genome Atlas has identified these 4 subtypes as CIN, which is chromosomal unstable, EBV, which is Epstein-Barr virus, MSI, which is MSI high, and GS, which is genomically stable. And these 4 subtypes have some unique features, and importantly, they also molecularly are distinct from each other. In this figure, we have an example of the different subtypes and different molecular characterizations of esophageal cancer from the esophagus all the way down to the antrum. So we can see proximal tumors tend to be squamous cell cancer, and they are associated with CCND1 amplification. And then we have an increase in CIN tumors, which begin at the GE junction and then move their way down into the lower stomach. The important part is that almost all GE junction tumors are the CIN subtype. That explains, for example, the ERB2 amplification, which is common in the CIN subtype. So putting this together with a disease paradigm, we think of cancer from a standpoint of genetic risk, environmental risk, and behavioral risk. And together these risks intertwine along with their molecular characterizations, and we can sort of understand the complexity of gastric and GE junction tumors. So we have this framework for different subtypes of gastric cancer, and over the ensuing several years, I think we'll begin to use these in our clinical decision making as to what treatments might be appropriate for what subtypes. We already see a sample of that, as we'll talk about in this talk, with HER2 targeted therapies. When we shift gears to patient selection for chemotherapy, we are reminded that for most patients with metastatic disease, the goal of treatment is palliation and to maximize durable efficacy. Patients with metastatic gastric cancer have unfortunately an incurable disease, but chemotherapy has clear proven benefits. It can extend survival, it can improve symptoms, and quality of life. Key factors as we think about chemotherapy involve their functional status, their age, comorbidities. We have many options for treatment, and we need to do some work in terms of molecular profiling to understand what are the best treatments for the patient. So following this flowchart, we can see that an important aspect is to identify if the patient has HER2 overexpression or ERBB2 amplification. If they do, specifically IHC score 3 or ERBB high amplification plus IHC2 score 2, then the best option will be a platinum 5FU plus trastuzumab option. If they are not amplified for HER2, then we would think of a platinum fluorouracil doublet. Sometimes we do think of a 3-drug regimen, such as the modified DCF or FLOT regimen. Those patients need to have a very good performance status, but if so, you may have a high response rate with the 3-drug regimen. We do think of the performance status, and that would impact us more for next line therapies such as paclitaxel or ramucirumab in the second line setting or TAS-102 in the third line setting for most patients. For HER2 positive cancer, we should start with the TOGA study, which is trastuzumab for gastric cancer, which was published in 2010, so almost a decade ago at this point. And this was a randomized study of cisplatin and capecitabine with or without trastuzumab in patients with HER2 positive disease. The study defined HER2 positive disease as IHC3+ or FISH positive. So there were about 100 patients in this study that were IHC0 or 1 and FISH positive. And if you exclude those patients, you see that patients who have true HER2 positivity with chemotherapy have a median survival of nearly 16 months. So that is the population that we tend to use for HER2 targeted therapy. Since that time, there's been a lot of activity in trying to improve the efficacy of HER2 overexpressed gastric cancer, and we've actually followed the course of new drugs examined in breast cancer. Pertuzumab and TDM1, these are two new HER2 targeted agents that are approved in breast cancer that were examined in gastric cancer in both the first line and second line setting. The JACOB study examined capecitabine, cisplatin, and trastuzumab with or without pertuzumab in a large patient study of 780 patients. And unfortunately, that study was in fact negative for overall survival. And the second line study was the GATSB trial, which evaluated TDM1, which is a drug antibody conjugate approved for breast cancer, versus paclitaxel. And this study was also negative in the fact that TDM1 was not superior to paclitaxel. So this gives us an idea that HER2 overexpressing gastric cancer is not the same thing as HER2 overexpressing breast cancer. HER2-driven gastric cancer is not as common. There's more heterogeneity of HER2 expression within the tumor, and it doesn't seem to drive the disease as it does in breast cancer. There are newer agents that we will talk about, so this remains an active area of investigation. In terms of second-line options, ramucirumab, which targets VEGFR2, really has a significant role in mainstay. So this is the REGARD study, which is a second-line study of ramucirumab versus placebo. It was a 2-to-1 randomization. And this study demonstrated clearly that there is a modest overall and progression-free survival benefit with ramucirumab over best supportive care. And the other study is the RAINBOW study, which examines paclitaxel with or without ramucirumab in the second-line setting. And this was a larger study examining the addition of ramucirumab to cytotoxic therapy, and it was in patients with gastric and GE junction tumor who had progressed on first-line platinum and 5FU-based therapy. And in this study, we demonstrated also an improvement in overall survival and progression-free survival. The hazard ratio for overall survival was 0.8, and for progression-free survival was 0.635. Both were highly significant. So based on these two studies, ramucirumab is approved in the second-line setting, and most of us would use it in combination with paclitaxel. So in the phase 2 study, there is a examination of nab-paclitaxel with ramucirumab. Nab-paclitaxel is a albumin-bound paclitaxel, and it improves the delivery within the stroma of paclitaxel. And so in this study, 65 patients were enrolled over a very short period of time, and it involved both the stomach, GE junction, and the esophagus. Most patients were stage 4, and about 30% were HER2 positive at study entry. And what we see from this study is that the progression-free survival was about 4 months, and the time to tumor progression was 4.5 months. Overall survival was 8.8 months, which is very comparable with paclitaxel and ramucirumab as well. So there is some encouraging data for this. So we have clear evidence that ramucirumab works in the second-line setting, but in the first-line setting, ramucirumab was examined with chemotherapy in the Rainfall study. This is an important study examining VEGFR2 inhibition in the first-line setting with standard cytotoxic chemotherapy. Recall the AVAGAS study was the first study that examined this, and it was in fact negative, but there seemed to be some patient populations that may have benefited. Additionally, with the earlier line studies with ramucirumab, we found that giving a higher dose of ramucirumab might be better and more advantageous. So the Rainfall study had some key features that we implemented that we hoped may make an impact with regard to efficacy. We gave a higher dose of ramucirumab. We gave it on day 1 and day 8 every 3 weeks instead of every other week as is standard in the second-line setting. We also tried to provide a better balance for patients across the globe for enrollment, which was not done in the AVAGAS study. The primary endpoint for the Rainfall study was overall survival, and unfortunately, despite these modifications to optimize the benefit of ramucirumab, the study was in fact negative. So it's very clear that ramucirumab targeting VEGFR2 does have activity in the second-line setting in gastric cancer. We should not use it in the first-line setting based on the data from Rainfall. Moving to third line, I'd like to talk to you about an important study that was published by Dr. Shitara in Lancet Oncology. This is a third-line study of trifluoridine tipiracil versus best supportive care. This was a 2-to-1 randomized study of about 500 patients. And as you can see from the Kaplan-Meier curve, patients who were randomized to trifluoridine and tipiracil actually did significantly better. The curves split early and they stay split throughout the duration of the study. The hazard ratio is 0.69 and the one-sided p-value is 0.00029. So moving to immunotherapy, we can't have a talk on gastric cancer without having a discussion of immunotherapy nowadays. In gastric and GE junction tumors, pembrolizumab was examined in this study, Keynote 12, initially. And this was really quite exciting because this was an early look at how active this drug could be. You can see that from the Kaplan-Meier curve, patients who responded to the treatment responded quite nicely. The median overall survival from this phase 2 cohort was about 11 months. And again, this is in the advanced setting where you wouldn't expect patients to live more than a few months. Also of note is that there seemed to be equal efficacy in patients from Asia versus the rest of the world, which was unique, at least at that time. Keynote 59 is a phase 2 study of pembrolizumab. There are actually 3 arms. So the arm that I'm talking about here is the single agent pembrolizumab in the third line setting for gastric and GE junction tumors. This is cohort 1 that's boxed. So the combined positive score looks at PD-L1 staining of tumor cells, lymphocytes, and macrophages, and divides that over the total number of viable tumor cells. And we see that a combined positive score of 1 or higher is considered positive. Here are 2 photomicrographs of a negative and a highly positive tumor, 2 separate tumors. In patients with advanced gastric cancer, we see the overall response rate of about 11%. In the box, you see the tumors that responded even a little bit, and there is an enrichment for the PD-L1 positive patients, which are the darker bars, compared to the tan bars, which are PD-L1 negative. So some patients who are PD-L1 negative do respond, but there is clear enrichment in PD-L1 positive tumors. But the important part is this swimmer's plot. So if you are PD-L1 positive, your duration of response is 16 months. So these are the patients that are really getting the true benefit of immunotherapy, in this case pembrolizumab. The PD-L1 negative patients, they may have a response, but it's not long lasting. It's 6 months on average. So based on these data, pembrolizumab is approved in the third line setting for PD-L1 positive tumors, which is about 40 to 50% of them. The Attraction 2 study was a randomized study in the third line setting of nivolumab versus placebo that was run in Japan by the Ono group. We clearly see that nivolumab has activity similar to trifluoridine tipiracil in the third line setting that we just saw. In Attraction 2, the Kaplan-Meier curves for overall survival, they split early and they stay split. Importantly, the Javelin study examined avelumab as a third-line treatment versus chemotherapy in gastric cancer. And unfortunately, when compared to chemotherapy, avelumab did not show benefit. This is an important study because it highlights that perhaps PD-L1 inhibition, which is what avelumab is, versus PD-1 inhibition, which is nivolumab and pembrolizumab, but it also demonstrates that the response to immunotherapy is robust in some patients, but not in most patients, and we need to think about how we can select patients better. And then I'd like to talk briefly about mismatch repair and how that can be an important biomarker for patients. A pan-cancer analysis of mismatch repair deficiency shows that colon cancer and stomach cancer are quite high. Nearly 20% of them have a mismatch repair deficiency. The other tumor that has a high mismatch repair deficiency are GYN malignancies. When applying mismatch repair deficiency to gastric cancer, this is an important study that looked at a very thorough analysis of molecular biomarkers amongst all patients with gastric cancer who received immunotherapy. And we see that CPS positive tumors really do enrich for a response. But also importantly, when you look further, you see that those CPS positive tumors are high in these the MSI high tumors and also EBV positive tumors. These are important biomarkers as well in gastric cancer. I'd like to summarize the current treatment status for gastric cancer and GE junction tumors. It is quite complicated, and we've gone through a lot of data in a very short time. In the first line setting, most would use a platinum fluoropyrimidine combination like FOLFOX, but cisplatin and 5-FU is also reasonable. Patients who have a high performance status may have benefit from modified DCF or the FLOT regimen. For tumors that are IHC 3+ or IHC 2+ for HER2 and FISH positive, we would consider adding trastuzumab. In the second line setting, we would consider ramucirumab-based therapy, most likely with paclitaxel. Irinotecan does have activity. In the third line setting, we think of trifluridine tipiracil for PD-L1 negative tumors or pembrolizumab for PD-L1 positive tumors. If you have mismatch repair deficiency, you can consider using immunotherapy in the second line setting. So as we consider treatment for gastric cancer, we need to think of more than just the efficacy of the drugs in terms of how we think of the patient. We need to think of side effects, toxicity. We need to think of the burden of disease. For example, if patients have a high burden of disease, they may need a 3-drug regimen. If patients have peritoneal disease, they may not tolerate a 3-drug regimen very well, and we may need to start with a 2-drug regimen. We need to think about molecular markers as well. Unfortunately, despite these advances, patients will still die of disease within a year or just over that. So we do need to balance the side effects with our overall goals of care as we plan therapy. So I'd like to move on to our case presentation. I guess I'd like to segue that we talked about standard of care in patients with metastatic disease, but we haven't really touched upon standard of care for patients with locally advanced disease. I'm here with Dr. Brandon Swed, who will present to you one of our patients.
Thank you, Dr. Shah. So this first case is really just to highlight the workup, staging, and management of patients with locally advanced gastric cancer. So it involves a 73-year-old gentleman.
A bit about his background. His past medical history includes coronary artery disease, COPD, hypertension, and hyperlipidemia. He has a family history that's notable for a brother with pancreatic cancer. He's currently a 12-pack-year smoker, significant drinking history of about half a pint of vodka daily. So he initially presented with a month of abdominal pain, nausea, vomiting. He had quite a bit of weight loss as well, about 50 pounds. His primary care physician referred him to GI for an outpatient EGD, but he wasn't able to get an appointment soon enough, so he ended up presenting to the emergency department because his symptoms became pretty intolerable and he was profoundly weak. When he arrived, he had a CAT scan that showed irregular circumferential wall thickening in the stomach from the antrum to the pylorus. And to follow that up, he had an endoscopy with endoscopic ultrasound that showed a gastric mass that was staged as T3. This was biopsied and then diagnosed as invasive adenocarcinoma. Further molecular testing of his pathology revealed that his tumor was microsatellite stable. It was equivocal for HER2 by immunohistochemistry, but negative for gene amplification by FISH. The combined positive score looking at PD-L1 gene expression was 10. And then to round out his staging, he had a PET-CT that showed no evidence of distant metastases or nodal involvement. and also underwent a diagnostic laparoscopy with peritoneal lavage that showed no malignant cells.
So to summarize, we have a 73-year-old gentleman with multiple comorbidities who's coming in with 1 month of nausea, vomiting, abdominal pain, weight loss, and found to have a locally advanced stage 2B gastric adenocarcinoma. He's got a reasonably good performance status with an ECOG of 1. So I'm going to turn it back over to Dr. Shah now to just discuss some first-line perioperative systemic treatment options for this patient.
Great. Well, that's a terrific case. Thank you, Dr. Swed. And there are some important things that are illustrative for this patient. The patient had a significant 50-pound unintentional weight loss. It's very common for patients. More than half of them will present with weight loss. And as we think about gastric cancer, we need to think about managing their nutritional status. That may involve placing a feeding tube or working with them, providing counseling. It may involve promotility agents. It may involve an endoscopy and placing a stent to overcome a distal obstruction or something like that. Additionally, the patient had a laparoscopy for staging, and that's not commonly done in the United States, I would say, but about 30% of patients with locally advanced gastric cancer will have occult microscopic disease in the peritoneum. It is a standard staging criteria, and we should think about doing that because it is important to identify patients who have metastatic disease. We can give them appropriate therapy compared to doing something that is non-standard because we didn't do a staging evaluation. PET scans are quite reasonable for staging gastric cancer. It does identify occult metastatic disease in about 10% of cases. In this case, the laparoscopy and the PET scan did not identify occult metastatic disease. So this is a patient that has a locally advanced gastric cancer. It appears to be T3N0, and the question is, what would we do at this time? So there are several standard options. One option to consider is from the MAGIC study, which is published in 2006 by David Cunningham, which involves perioperative chemotherapy with resection after 3 cycles of, in this case, ECF or ECX, and then surgery, and then 3 more cycles of that. Of course, based on more recent data, we don't use epirubicin in this setting, so we're thinking about a platinum doublet for about 3 months before and after surgery. Another option would involve surgery followed by postoperative chemotherapy and radiation. One thing to consider is that in the adjuvant setting, after having a gastrectomy, patients sometimes are slow to heal. They need time to adjust to having frequent small meals. Sometimes they have dumping syndrome. So I think a preferred approach, certainly at most academic centers, would be a perioperative chemotherapy that is based with platinum and 5-FU. And then most recently, the FLOT regimen was demonstrated to be superior to platinum 5-FU in patients who are able to receive FLOT. So that would be our preferred standard regimen for most patients who are eligible. This patient, a little bit older, 73, multiple comorbidities, I think I would use FOLFOX in this patient in the perioperative setting. Thanks, Brandon, for presenting this case and allowing us to discuss some important issues on perioperative staging. Let's stay tuned for the next segment of the program where we take a look at how to provide not only optimal treatments, but also provide the best care to patients. Welcome back. I'm here with Hillary, who I work closely with. She is on the front lines taking care of our patients with gastric cancer. Welcome, Hillary.
Thanks, Dr. Shah.
In this segment, we're going to take a look at how we provide patients with a positive treatment journey where we manage our patients' symptoms and focus on a holistic approach, thinking about their well-being. We talked about the different options for therapy, but as we all know, taking care of a patient is more than just the drugs that we use. It also involves what's actually bothering them and how can we help them. This involves a very important interaction between the patient and the caregiver, and in our case, we're very fortunate to have a team that helps with all the other aspects of their care. Hillary will share her thoughts on how we provide multi-directional approaches to care as we focus on symptom management, psychological support, nutritional considerations, and other patient-centered issues.
So from the first appointment, it's really important to utilize a multidisciplinary care team. We should engage surgery, radiation oncologists, radiologists, palliative care, and social workers when appropriate to help manage this patient's care. The chemotherapy nurses at our clinic are also a great resource for patients. They know a lot about managing symptoms and side effects, as well as they can guide the patients through their infusion that they'll be having in the chemotherapy suite. It's really important for all of our care team members to have strong communication with each other so that we can update each other on the patient's care and progress. So care really starts before treatment begins. It's really important to assess the patient's nutritional status and to refer to our nutritionist when appropriate. We should know if a patient's having difficulty eating or drinking, having weight loss, or even just wants to know more about optimizing their nutrition prior to starting treatment. The nutritionists are also a great resource for helping patients learn more about supplements, and they're also great at building a key relationship for the patient from the beginning of their treatment through the end. Our social workers are also really important. They can help patients with transportation, getting meals to their house, engaging them in support groups, and working on coping mechanisms with them. We should also assess patients' tobacco and alcohol use prior to starting. Our palliative care team is also really important. It's important to dispel the myth that palliative care is only used for end-of-life care. They can help with talking about goals of care, engaging patient support systems like family and friends, as well as discussing symptom management for uncontrolled pain or other uncontrolled symptoms. It's important to build this relationship from the start so that there's good rapport for patients and family members throughout. So some symptoms that patients may have is bleeding from the cancer itself or just from irritation. So for these patients, it's really important to discuss possible symptoms, especially of an upper GI bleed. So asking them about things like dark tarry stool, is the stool sticking to the side of the toilet? Are they having any coffee ground emesis or bright red blood when vomiting? It's important to also know, are they on any sort of blood thinner? If we're concerned about a GI bleed, we can bring them into the hospital to get them assessed, where they can have an endoscopy to see if they are having some sort of bleed. The endoscopy can be helpful as a therapeutic source as well to help stop the bleeding, but we can also use things like embolization or EBRT to help with this. We can also start patients on a PPI to help reduce the risk of a further bleed. So it's important to monitor patients for anemia while they're going through treatment, prior to treatment, as well as during the surveillance period. So we can do this by monitoring their CBC, getting iron studies, as well as monitoring their B12 levels. We can also check their albumin levels as well to see what their nutrition status is and if they need to have some sort of protein supplementation, or whether it's in the form of shakes or just added snacks even throughout the day. We should also make sure that we're monitoring patients' B12 levels post-gastrectomy. And we can begin patients on B12 supplements orally or through injection in the clinic, as well as we can start patients on some sort of iron supplement while they're at home, or bring them in for an iron infusion if needed, as well as just to talk with patients about possible symptoms of anemia. Sometimes our patients who are post-gastrectomy bring up the symptoms they may be having years out, and then we can have them come into clinic and monitor these and treat them appropriately. Pain is really important to assess for every visit. It's important to know that pain can change throughout, so we should assess the pain at each visit as a separate thing. So we should understand the onset of the patient's pain, the location. One person's right upper quadrant pain may be very different than another person's, so it's important to ask them exactly where it is. We should look at the duration of how long their pain is lasting. Is it throughout the day, or is it just for a couple minutes after they eat? What are the characteristics of the pain? Is it dull? Is it aching? Is it stabbing? As well as what are some aggravating factors? Some patients will say every time they eat, they're having a lot of pain, or when they're moving. And what helps to relieve the pain? Is it heat? Is it eating certain foods? And what treatment have they already tried? There's a lot of different modalities: opioids, non-opioids, topical therapies, as well as non-pharmacological therapies, such as acupuncture, that some patients find to be really helpful. And this is an important point where we can work with our palliative care team to help control some of these uncontrolled symptoms related to pain. Patients may have nausea and vomiting from their chemotherapy, but it's also important to see if the nausea and vomiting is separate, because we need to assess for something like an obstruction. So antiemetics can be used for patients who are experiencing nausea or vomiting related to chemotherapy. We often try different antiemetics because some patients have relief with different ones. Making sure that patients are eating small meals throughout the day and increasing their hydration, as often patients tend to feel pretty nauseated if they're dehydrated. A bland diet like ginger ale, proteins like chicken, bland foods can also be helpful. And it's also helpful to sometimes provide patients with antiemetics prophylactically after chemotherapy to avoid nausea and vomiting on the days after they receive chemotherapy. So patients also may experience reflux or some indigestion. We can provide patients with PPIs or H2 blockers to help with these symptoms, but it's also important to educate patients on lifestyle changes that can help. So avoiding spicy or acidic foods, alcohol and carbonated beverages, those can all be helpful, as well as elevating the head of the bed, so using like a wedge, or even just putting blocks or books under the head of the mattress, because often patients will stack pillows and they just slip right under. It's also important for patients to sit up for about 2 hours after they eat, or walk around so that they're not laying flat after eating. Patients can also sometimes benefit from antispasmodics or antacids, or trying things like simethicone for excess gas, or even just peppermint tea or ginger can help. So it's important to assess patients for a GI blockage. Sometimes patients will call and they'll say that they're having a lot of uncontrolled nausea or vomiting. And it's important to assess them to make sure that they're not having a lot of excess belching, inability to eat or drink, or increased pain or symptoms with PO intake, as well as making sure that they're having bowel movements, passing gas. If they are having a lot of these symptoms, we can bring them into the hospital and get a scan for them to be assessed. So sometimes an endoscopy can be done to place a stent or bypass, or some sort of diversion can be done to alleviate these symptoms and hopefully allow the patient to have PO intake. And this is important to work with in a multidisciplinary care team and work with our GI doctors to help to alleviate these symptoms and find out what's going on for this patient. Some patients post-gastrectomy may experience dumping syndrome, and this can occur due to the anatomical changes after surgery. And it can result in food moving too quickly from the stomach into the small intestine. So some of our patients may experience cramping, diarrhea, nausea, flushing, sweating, or a drop in blood sugar from the dumping syndrome. And there's late and early dumping syndrome. So in early dumping syndrome, patients tend to experience this shortly after the meal. And late dumping syndrome, it tends to happen more about 2 to 3 hours after. Patients can make some lifestyle changes and modifications to help with dumping syndrome, such as eating small meals throughout the day rather than 3 large meals that we're used to, eating slowly and chewing well, as well as eating a lower carbohydrate diet or having carbohydrates as part of the meal instead of the main meal. Patients can also increase protein or fiber and avoid foods with a lot of sugar in them, as well as making sure that they're having their fluids separate from the meal itself. For patients where those lifestyle modifications don't work, we can try drugs such as acarbose, which is a drug that interferes with how your body absorbs carbohydrates. And it's given to control blood sugar after the meal and relieve the symptoms of late dumping syndrome. Octreotide can be given for both late and early dumping syndrome, and it limits how much insulin the body releases and how quickly the stomach empties its contents into the small intestine. If needed, reconstructive surgery can be done. A lot of our patients may experience anxiety related to their diagnosis, treatment, or even during the surveillance period. So patients need to be provided with a comfortable and relaxed environment where they feel that they can ask questions, express concerns and worries. We should really encourage patients to participate in their care plan and to be part of all of these discussions. Patients should be given the opportunity to speak with a social worker or a clergy member or somebody else if they have any questions or just want to spend more time discussing any feelings, concerns. When they're in the hospital, it's a very overwhelming experience and they're discharged home with a lot of new instructions. So all appointments should be made prior to discharge. So if they need social work to be involved, to schedule things like PT, OT, or any sort of home care, these should all be set up before they leave. Patients and family members and friends should really be involved in discharge care planning. So teach back is really important. We should ask them about new routes of medication, new drugs, new dosages or scheduling, as well as diet, nutrition, and activity that they'll be doing once they're discharged. So nutrition is really important to monitor while patients are getting their treatment and afterwards. Weight loss can be due to pain, it can be due to treatment itself or anatomical changes that we just discussed before. So patients should be encouraged to eat small meals throughout the day, high protein foods, and then they should always review any vitamins or supplements with their care team prior to taking them so that we make sure that they don't interfere with their treatment. Long-term side effects should be brought up to patients when they start treatment so that they're not unexpected after receiving treatment. It's important to promote healthy habits for patients, so it's important to keep their other care team members engaged in their care. If a patient has diabetes, it's really important to work with their endocrinologist or primary care doctor to help to manage their care. Patients should continue to have follow-up with their primary care doctor during treatment or afterwards as well. We can work together to manage their care and help to discuss any sort of scopes or scans or labs that they might have after. Patients should always be educated on what labs that they're having drawn at each visit. We should always discuss the biomarkers that we've already talked about that we're testing for and how this may impact their treatment plan and what they mean. And we can go over staging with patients as well. We should always be prepared to discuss with patients their diagnosis, their prognosis, what choices they have regarding treatment, as well as what each treatment will entail, how many days per week they'll need to be here, what kind of side effects they may experience, and how we'll help to manage these. We should always ensure that patients understand that they're part of the treatment plan and that we work together as a group to help manage their care.
Thanks, Hillary. That was really an incredible and valuable discussion and very informative.
So now I'm happy to be joined by Jennifer, a patient of mine and Dr. Shaw's. So I first met Jennifer last fall when she was diagnosed with metastatic gastric cancer. So I wanted to take this time to learn more about your journey and what it means to you.
Hey, Hillary. Glad to be here.
Hello. Let's first just talk about how your journey started. What were you feeling prior to your diagnosis?
Sure. Actually, I felt really great before my diagnosis. I was very active. I worked out a lot. The only thing I had was heartburn sometimes. And I went to see my primary care over the summer, and she said, just take some, Pepsid for a couple of weeks. If that doesn't go away, then make an appointment with like the gastroenterologist. So I did that, but of course it takes like a couple of months to make an appointment. And then I still had some heartburn, but nothing else. And then all of a sudden I started, one night I had tremendous flank pain, and I went to the ER and they did a CT and saw a bunch of stuff, and it's a very quick diagnosis. Like one day I felt fine and the next day I went off a cliff.
When you came to Dr. Shaw, what tests had you already had done, and what testing was there left for you to do after you saw both us and other doctors?
Yeah, so I think from time of diagnosis to seeing Dr. Shaw was very quick, like I think 2 weeks. But I was in the hospital, like I said, and they quickly kind of figured out there was something terribly wrong, although they never used the word cancer with me. They used a whole bunch of other things, which I then figured out like a week later. But I saw my primary care, I saw a urologist, I saw my OBGYN, And then finally, a week later, I was referred to a local oncologist, but, and I had an endoscopy.
Yeah, and I know when you came to Dr. Shaw, you had already had the CT scans and we were getting a PET scan.
Yeah.
And so there was still some testing left to do. And we looked at some of the like biomarkers. We were looking at like your HER2 and PD-L1. How did you and your family feel kind of when you were getting all of this testing, especially since, you were just saying that, no one really used the word for you, this seems to be cancer.
There was a flurry of activity, like I said, that first week after going to the ER, where I saw a bunch of doctors and I didn't really know what was happening, but I, Googled up a bunch of words. And then by the end of that first week, I was like, huh. And then when I saw my primary care, I asked her, I was like, just be straight with me. And she told me, yeah, most likely it's cancer. So before I even had the results back from my biopsy with the endoscopy, it was pretty evident that's what it was. So I appreciated her honesty. And so when I got my biopsy results back, I saw my local oncologist, who I guess knows Dr. Shaw. And, he was wonderful. It spent a lot of time with me, answered all my questions. Of course, I really didn't know anything about cancer.
Right.
So he spent a lot of time with me, answering my questions, and then, said, hey, I'm going to make some phone calls. You might, qualify for some clinical trials. And I was very quickly put in contact with Dr. Shaw.
What were those questions?
Well, obviously, I wanted to know what stage I was. And he told me stage 4 and what that meant. I wanted to know what treatment was available. And he said chemo, but also mentioned, about the possibility of getting into a clinical trial. And, of course, I asked for a prognosis because, by this time I had Googled stuff.
Mm-hmm.
It's not good. And, I talked about how my health just went off a cliff. So he said that once I started getting treatment, that I would feel immensely better. And that did pan out.
Are there any questions that you wish you had asked at the beginning?
I got a lot of information because I'm the type of person, like, I write down everything in notes. I had a lot of questions. And I think I did the same thing to Dr. Shaw as well, and to you.
Yes.
So,
it's good to do that because I think, otherwise sometimes you go into these appointments and you're overwhelmed to begin with. And then, this way you have the questions and the responses in front of you so that you can kind of check off.
Right. Obviously, I wanted to know about the treatment and prognosis. And we had talked about, the markers and how that would determine, I guess, my participation in the trials.
Yep.
Yeah.
Yeah, because you originally, I think, were looking at 2 different clinical trials, if I remember. Right. And how did you decide to enroll in the clinical trial versus just standard of care treatment?
I qualified for 2 clinical trials, and I learned that chemo, which is the standard of treatment, would be included in that trial. So really the trial portion is the one that I could potentially, gain better or more benefit from. So I was definitely interested in that. And as far as deciding between the 2, I think in discussion with Dr. Shaw, he laid out, I think one had, some people had maybe some side effects that prevented them from getting the full treatment. He felt like it was important to get full treatment, and that's why we decided on the other.
Yeah, and you started treatment, I think it was about within a month of your diagnosis. What are some things that you found helpful to know about your treatment prior to starting?
So I understood the chemo portion and how that was systemic, and destroys the cancer as well as other cells in my body and all the side effects associated with that. But the immunotherapy portion, I guess, was the most interesting. And so I was really excited about that. And and Dr. Shah explained how each trial worked and, the mechanism involved. And I'm kind of a science geek, so I really appreciated his explanation. And I looked it up and read more about it. So I felt like I could make a really informed decision.
Yeah, and were there any issues you had enrolling in the trial or any like logistical pieces that were difficult?
The entire team, Dr. Shaw, you, Hillary, and Sabrina, and everyone involved was so helpful and accessible. And I think I called Sabrina like a whole bunch, like several times a day, with questions. And I think the difficulty in the first month was just trying to, because I'm not local, I'm maybe an hour away from the facility. So trying to coordinate between my local oncologist and handing off some of the tests that I had gotten in my local medical facility and transferring it to Cornell, and all the tests, various tests, many tests involved. Just that took a lot of time that first month. But other than that, it was very, I felt like I was, guided the entire way, that I had a team that was very accessible. And so that was terrific.
Yeah, no, it's really helpful, I think, to have like Sabrina, who's one of our research nurses, because she is just able to answer all of those really specific questions about the trial and what things we still need and how the trial works, like when your appointments are. So
Right.
I think that, she's an integral part of the clinical trial experience for patients. What did your first day of treatment look like? How did you feel after?
It was very different from what I expected because, all I knew about cancer and its side effects is like what you see in the movies. And so it was very different because I didn't have those very extreme side effects. I didn't like throw up or anything like that. I had very mild nausea. So the day of, I came in, I got the infusion. I had to wait for the blood test results and to get the immunotherapy. But, it was pretty straightforward. I sat there. My husband came with me. The facilities are very nice. The nurses are, of course, wonderful. And, I went home with the pump, and that was all explained to me. And I was set up at home. So I felt good. Like I said, I didn't have drastic side effects. I only had very mild nausea and some headache, and I had drugs for that. So it wasn't bad.
What were kind of some helpful tools? I know you mentioned you had the anti-nausea medication, you had Tylenol if you needed for headaches, but what were some other kind of tools, whether having family rounds, eating crackers, like that you found to be beneficial after chemo?
Gosh, there were so many things that I had to prep. I had, of course, all the different medications, the anti-nausea, Tylenol, I had Imodium, I had, the laxatives, I had everything. Then I also prepped my bedroom. So I got like a backrest. I got like memory foam for my bed, and I got a heating pad, and just trying to make my bedroom kind of my sanctuary and make it comfortable, to hang out in and rest.
Yeah.
And as far as support, my husband's been awesome, wonderful. My kids have really stepped up and amazed me. And, yes, of course, my friends were there for me, but what's been really surprising to me is kind of like people who are just acquaintances, like my mommy friends in the neighborhood, my neighbors, people I kind of casually know, but not that well, have really stepped up and been so helpful.
Yeah, I think having a network is really important to managing side effects, also just getting to and from appointments, especially since you live, an hour away, making sure you have that. I think, at the beginning, we gave you some IV iron because you had iron deficiency anemia. Were you having a lot more fatigue or shortness of breath or any profound symptoms?
No, not profound symptoms. I mean, I felt tired, but the thing is, in the beginning, when you're going through it at the first few months, I couldn't really tell what was happening because of the chemo or because of the cancer, or
Right.
there was just so many things going on with my body. I couldn't tell why.
Yeah. I remember you went to see the nutritionist or they came to see you because you had been losing weight or just difficulty eating, I think was the issue because you were so bloated. Did you find the nutritionist to be helpful?
Yeah, so I spoke to a nutritionist in the very beginning. I had been losing weight and I had zero appetite. Like I was forcing myself to eat. I literally just could not even force food down.
Yeah.
So she was very helpful, in giving me tips about how to maximize calories, in small portions. And I wanted to mention that there are a lot of very well-meaning people. So in the beginning, when people learned about, my cancer, they want to be helpful and they want to tell you all sorts of things that they've read or TED Talks or books and crazy dieting ideas and supplements. And I just very kindly thank them.
Yep.
It's a lot of very well-meaning people, but of course I would defer to you and Dr. Shaw, as far as treatment.
You were saying in the beginning that you saw your primary care doctor, you saw a nutritionist, you saw different oncologists. Were there any other people that you saw? I know you have other people who are now managing like specialists, but I guess who are those people? What parts do they have in your care team?
Right. So right now I see a urologist because I have stents in both my ureters. And I guess that's what clued me into the gastric cancer is it was kinked up and caused my kidneys to swell. So that's still an ongoing thing. I get my stents swapped out every 3 months.
Yeah.
And I guess the latest thing is you mentioned I have a thyroid thing, so I'm supposed to have a televisit with a endocrinologist.
Yeah. Yeah. And I think, one thing, especially when patients are getting the immunotherapy, we really watch your thyroid levels. So I think it's, great that we have at Cornell, we have all of these specialists who can really work with us and work with you to help manage these different aspects of side effects from these drugs. So now that, you've been getting treatment, what do your visits now look like compared to maybe when you started? Do you feel more comfortable?
Yeah, so now since January, I've only been getting the immunotherapy portion. So it has been very different because when I was getting the chemo, I had much more significant side effects, like not just the nausea and whatever, but I think the biggest one was the cold sensitivity. Was pretty intense. And I would have to wear gloves pretty much all the time.
Yeah.
Like even in room temperature, it was really intense. But now, yeah, I'm just getting the immunotherapy. So I still have neuropathy in my hands and my feet, but not the cold sensitivity anymore. And I feel maybe a little bit tired right after the infusion, but I feel really great, almost normal.
Yeah, and I guess on that note, has your daily life changed at all since starting chemotherapy and immunotherapy?
Well, I mean, during chemo, it was very different because it was kind of all hands on deck. I was a wreck physically and emotionally, so really depended on, my husband and my family and my friends. But, now having just being on immunotherapy, I feel a whole lot better. So My daily life is pretty normal. Like I've been working a whole lot lately.
Yeah.
I cook a lot. I exercise. I do stuff with my family. So it feels really normal.
What are 3 things that you think every patient with gastric cancer should know?
You know, you need to get treatment. You know, you need to find a doctor and a, medical care team that you feel comfortable with.
Mhm.
So all of that aside, it's kind of slow this down. I think it's important to keep your sanity and try to find a way to keep on living because it's a new normal that you have to adjust to.
Yeah.
Um, and connected with that, as I said before, don't be shy about asking for help because people really want to help. You know, they feel helpless. It's almost like working in reverse. Like they feel so bad and I have to make them feel better. But a way of doing that, actually, I figured out is to give them specific tasks.
Right.
So I wasn't shy about asking for, like I said, for them to pick up my kids and drive them around to their activities. I never refused offers of, food or cleaning. Um, a lot of people wanted to visit in that first month or two.
Mhm.
I welcomed their visits. I always made time because I didn't know how long I had. So I always said and they know, oh, this is the other thing is that people feel like they're intruding on you. And I told them, you're not intruding because I had this favorite phrase that I came up with. I was like, come visit me now while I'm alive. Don't come visit me when I'm dead, So that's one. That was a long one.
Well, that's a good one.
Two, I would say that, these are kind of like general thoughts about life is that, life is unpredictable. So to cherish each day and that, I guess 3 I kind of already touched on, but surround yourself with good people, people who are going to support you and be positive.
What are a couple of things that you wish your care team at Cornell, or even when you were first diagnosed, that they had told you or that you could have told them?
I'm the type of person that likes to be told things. So, I appreciate when doctors are brutally honest with me and not try to sugarcoat things. I also like to know the whys of why things are done. So that I could feel, not that I want to question my care, but I want to understand it.
Yeah, no, I think those are important and, important in advocating for yourself, which I think you do a really good job of.
Yes, agree with what you said about advocating for yourself because, you know your own case the best, and doctors, however well-meaning they are, they have a lot going on, and so you need to stay on top of your own schedule and remind doctors about, oh, you mentioned this last time, and just making sure that you're on schedule with all of the various tests and visits like in the beginning.
I think we got a lot of great information and better understanding of what your diagnosis and your journey has been with gastric cancer. So thank you.
Okay, my pleasure.
Thanks, Hillary. That was an incredible and valuable discussion and very informative. I might just add a little bit about the COVID pandemic and how we're managing patients now. As you know, we're doing a lot of video visits, and I find that patients really find it quite valuable. Obviously, we were talking to patients a lot on the phone earlier, but now we're encouraging patients, and we're able to do many more video visits, and it really is valuable for us to actually see a patient even over the phone or over the iPad. Patients like the idea that they can see me and we can talk, and we can actually pick up a lot about how patients are doing. Obviously it's not as good as seeing patients in person, but for much of what we do, I find that it has actually been quite helpful. Do you have anything to add to that?
Yeah, I think the video visits and the telephone calls have been really important. It's important that we stay in touch with our patients even if they're not coming into clinic. So, reviewing side effects and symptoms, I find it's important to call patients even if they don't call me so that we can stay in touch and really learn what's going on. I think patients sometimes are afraid to call because they think it with everything going on that is too overwhelming. But it's really important to sit down with them and go over, how they're doing, both physically and psychologically, with everything going on, and to really manage these symptoms from afar, as well as to review their labs with them, and just review their schedule and see when they possibly either could come into clinic or when they would like to touch base next.
So thanks again. I'd like to invite you to stay tuned for the next section where I'll be reviewing emerging strategies and we'll discuss more on the exciting data regarding gastric cancer treatments. Thank you. Welcome back. In this third section of the program, I'll be reviewing the novel therapeutic strategies on the horizon in gastric cancer. Several clinical needs still exist, and we'll go over the rationale, clinical designs, and the latest evidence of emerging strategies being examined. So I'd like to begin with HER2-targeted strategies. One is DS8201, and then there's RC48 ADC, which is an ongoing phase 2 study. We'll also talk about margetuximab, which is a novel HER2-targeted antibody that has been modified specifically to improve ADCC. That may improve the immune response with targeting HER2. And then there is a new antibody, ZW25, which is a bispecific antibody. So the phase 1 study of trastuzumab deruxtecan, which is DS8201, was actually published by Dr. Shitara in Lancet Oncology in 2019. This was a phase 1 study that involved both gastric as well as breast cancer patients. Generally, the treatment was well tolerated in the gastric cancer cohort. The overall response rate was about 43%, and the duration of response was 7 months. At this past ASCO, we saw the results of the phase 2 study suggesting that DS8201 does have significant activity in gastric cancer HER2-positive disease. So the next drug I'd like to talk about is margetuximab, which is a modified antibody that targets HER2. It specifically is modified to enhance ADCC, antibody-dependent cell cytotoxicity, when targeting HER2. I'd like to talk about an ongoing study, Keynote 811, which is also a very exciting study involving chemotherapy and trastuzumab with or without pembrolizumab. This is a first-line study that is already approximately 1/3 accrued, and the primary endpoint here is both progression-free and overall survival. And there is initial data that when combining HER2-targeted antibody therapy with immunotherapy, you do have activity. When we're thinking about immunotherapy combinations, it's important to recognize the combination studies that have been examined so far that have largely been negative in gastric and esophageal cancer. Keynote 62 was a first-line study evaluating chemotherapy versus chemotherapy with pembrolizumab or pembrolizumab alone in the first-line setting. PD-L1 positive was defined as CPS 1 or higher. And as we can see, it was also a complicated design where they were splitting the alpha for multiple primary endpoints. The first endpoint I'd like to talk about was pembrolizumab versus chemotherapy, which was one of the main primary endpoints. For this comparison, we're looking at non-inferiority. We're asking, does immunotherapy in PD-L1 positive patients, is it equivalent to chemotherapy? And the hazard ratio is 0.92. The non-inferiority margin was 1.2, and so it actually did meet that endpoint. The margin for non-inferiority was just above that. So technically this was a positive study, but what we really see from this curve is, again, the crisscross. Initially, patients who received chemotherapy did better, and then at around the median, about 12 months or just earlier than that, there was a crisscross, and then patients who received immunotherapy did better. So it suggests that, again, if we had a better biomarker, we might be able to give immunotherapy to the right patients without harming patients who did not get chemotherapy. We can see that with the CPS 10 or higher. So there we still do see a crisscross, but the magnitude of benefit with immunotherapy is quite substantial. The progression-free survival is illustrative. If you receive immunotherapy and you don't benefit, you progress immediately. And the danger of that is that you may not then be well enough to receive substantial ongoing therapy. So we need to sort of figure out the right way to give immunotherapy in earlier line settings. I think in my practice, I would not give immunotherapy by itself because of this concern, at least in the earlier line setting. So Keynote 61 is a phase 3 study looking at pembrolizumab versus chemotherapy in the second line setting. The chemotherapy was paclitaxel. And as you can see on the Kaplan-Meier curves, patients who have CPS 1 or higher, that's the middle curve, show only a minimal improvement in overall survival. The hazard ratio is 0.82. For the first time, you see this kind of crisscross design that initially chemotherapy did perform better, but then after about the 8 or 9 month mark, which is around the median, then immunotherapy started to do better. So it really does suggest that immunotherapy does have significant activity, but in a portion of patients, and we just haven't identified that portion very well. If you are more stringent with regard to PD-L1 staining and the cutoff for positivity, so you look at the right Kaplan-Meier curve, you see that for CPS 10 or higher, you begin to see a clear separation where that immunotherapy really seemed to have benefit and you don't see a crisscross. For that cohort, the hazard ratio is 0.64, which is really quite encouraging. And then conversely, if you look at the CPS less than 1, so essentially CPS 0, you see that immunotherapy never is better than chemotherapy. In fact, immunotherapy does harm. So this actually really teaches us that you really do need to test for the CPS staining before giving immunotherapy, at least pembrolizumab, in this disease. And then Checkmate 649 is a first-line study examining platinum, FOLFOX, or XELOX with either nivolumab or nivo and ipi. This is a large study of 2,000 patients, and we expect the results of this later this year, early next year. The Javelin 100 study was an important study looking at maintenance first-line chemotherapy versus avelumab. This was a study examining overall survival. If you actually have not progressed on chemotherapy after 4 cycles, and then you randomize patients to receiving continued chemotherapy or maintenance therapy versus avelumab. And unfortunately, the Kaplan-Meier curve shows really no difference in outcome in that study. So based on that, we think that maintenance immunotherapy is actually not a good strategy for our patients. Another antibody, sintilimab, was examined with XELOX in the first-line setting, and there was a very encouraging response rate of 85% without significant toxicity, and notably a 100% disease control rate in this small phase 1b study. But based on the results, a phase 3 study actually has been initiated. This is the Orient 16 study looking at CAPOX with or without sintilimab, and we look forward to those results as well. Finally, another strategy of improving immunotherapy is to combine it with VEGF inhibition. Inhibiting VEGF or VEGFR2 suppresses tumor growth. It may alter the micrometastatic niche, and it may actually augment the activity of immunotherapy. Anti-angiogenic agents have immunomodulating effects, and it may restore anti-tumor activity by altering the tumor microenvironment. So there recently was published the phase 1b study of durvalumab with ramucirumab, and this is a large study that looked at multiple cohorts, gastric, lung cancer, and HCC, and there are suggestions of activity with this strategy. Another study looking at nivolumab and ramucirumab was also presented at ASCO this year, and similarly we see some encouraging activity with response rates in the 30 to 40% range, which is really quite encouraging and more than you would expect with paclitaxel and ramucirumab alone, for example. So finally, another way to augment activity is to combine target agents such as TAS-102 and ramucirumab. So that study is ongoing, and we look forward to those results. Other ongoing studies are listed in this table. We have the SEQUEL study looking at pembrolizumab with ramucirumab in a phase 2 cohort. We have PARP inhibitors combined with immunotherapy or VEGF inhibitors as well. Those are phase 1-2 studies. And then we have avelumab, which is a PD-L1 inhibitor with ramucirumab and paclitaxel. So there are a lot of strategies trying to combine our target agents in the advanced setting to augment activity. Other studies involve VEGF tyrosine kinase inhibitors, fruquintinib, or FGFR2 inhibitors. That's bemarituzumab plus FOLFOX. And then very exciting data on zolbetuximab, which is a anti-Claudin 18 antibody in combination with chemotherapy. The Spotlight study is in combination with FOLFOX, and the GLOW study is in combination with CAPOX. And those phase 3 studies are registrational and well on their way. So now that I've reviewed the current and emergent treatment strategies in gastric cancer, I thought it would be very good to have another patient case presented by Dr. Swed. Dr. Swed, welcome back.
Great, thanks, Dr. Shah. So this was our patient who was diagnosed with metastatic gastric cancer. So she's a 90-year-old lady with a history of coronary artery disease, hypertension. She had early stage breast cancer that was diagnosed at age 64, for which she underwent lumpectomy followed by radiation therapy. She was recently diagnosed with metastatic gastroesophageal junction adenocarcinoma, and she had mets to her lungs. And her tumor profile was notable for microsatellite stability. She was HER2 negative by immunohistochemistry, and her combined positive score was 20, looking at PD-L1 gene expression.
She received a total of 6 cycles of palliative FOLFOX, which she tolerated well, but unfortunately she had progression of disease. And currently her performance status is great. She remains ambulatory. She's fully independent. So Dr. Shah, did you want to comment on reasonable second-line treatment options for this patient?
Yeah, so I think this is an important study because the patient is elderly. She's 90, but she's highly functional. So one thing to consider here is that patients who remain functional should be considered for second-line or third-line therapy. We shouldn't limit a patient's options just because of age. So this patient, really, she's independent and functional and quite active, and there is a survival advantage to consider second-line therapy.
Great, thanks. So she went on to receive 2 doses of paclitaxel and ramucirumab.
One thing to consider, though, is whether a patient like this might tolerate cytotoxic therapy, or you might consider ramucirumab as a VEGF inhibitor by itself without cytotoxic therapy, and that may mitigate some of the side effects that you would see with chemotherapy as well. Also, in the COVID era, the paclitaxel ramucirumab combination is a combination you would give weekly, 3 weeks in a row and a 1-week break. Ramucirumab alone you could give every other week. And in fact, we've done that with some of our patients to try to mitigate the number of times they need to come into the clinic to limit their exposure. So those are some things that we might consider during the COVID crisis.
And then Dr. Shah, what, if anything, would you consider for third-line treatment for this patient?
Yeah, so that's a great question. As we know, there are several third-line options that we could consider. One is trifluridine tipiracil that was recently approved for third-line patients who are PD-L1 negative. This patient has a CPS score of 20, so we could consider pembrolizumab as well. In someone who's a little bit older, I am very careful to think about side effects. We think of immunotherapy as drugs that are generally safe, but patients who have, for example, bad arthritis, they may actually have reactivation of arthritis with PD-1 inhibition therapy, so that's something to counsel patients on. Trifluridine tipiracil is an oral agent. You don't have to come into the clinic too often, so that might be something to consider as a preferred option in this time of crisis with COVID. The other options might be irinotecan. That is associated with hair loss, so you might think about that as we think about managing a patient's side effects with treatment. These are all the options that you would consider in the third-line setting. I think given her high CPS of 20, my preferred option would be pembrolizumab if there were no contraindications, such as arthritis or thyroid problems, or making sure that she doesn't have really bad inflammatory bowel disease. So thank you, Brandon, for this great discussion. I think it highlights very important points about continuing therapy. You know, there was an analysis of real-world treatments in 2018, and it involved almost 3,000 patients with gastric and GE junction tumor. And importantly, 26% didn't receive any treatment at all. That meant that about 74%, so just over 2,000 patients in this cohort, received first-line therapy. And of that cohort, less than half, 43%, received second-line therapy, and only 18% received third-line therapy. Part of that is because patients do decline as they go on from first to second or third line therapy. Part of it is that I think maybe patients aren't offered therapy that they could be getting. So I think it's important for us to realize that there are options for patients. So thanks so much for that. Do you have any other final thoughts?
I guess just to wrap up, I just like to highlight that in a disease with such high morbidity and mortality, it really is refreshing to sort of hear all of these new and promising treatment options for these patients, particularly in regards to targeted therapy and immunotherapy.
Excellent. Yeah, and I guess I would add that, given the number of options we have in gastric cancer, I think being familiar with them and thinking about how they can be modified based on data, not only with regard to what patient side effects may be, what their goals may be, but also the environment in terms of COVID and what we're dealing with regard to minimizing exposures, those kinds of things are important as well. So the more options we have, the more ways we can kind of use the data and give our patients the best care possible. So with that, I'd like to thank everyone for joining us today. We hope that you found this activity informative and useful for your practice.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/BBD860. This activity is supported by an educational grant from Lilly. For further information concerning Lilly grant funding, visit www.lillygrantoffice.com.